Welcome to our video on epiglottitis and croup. Let's get started. Here's our overview slide. Let's begin by discussing epiglottitis. With regards to this topic, we'll be discussing the general characteristics, clinical features, diagnosis, and management. Let's begin with some general characteristics. Epiglottitis occurs due to inflammation of the epiglottis and surrounding supraglottic structures. Epiglottitis was most commonly associated with Haemophilus influenza type B in the past. However, due to widespread vaccination in the United States, it's much less common. Even though there is widespread immunization, one must remember to keep Haemophilus influenzae on the differential, especially in children who are unvaccinated or who have immigrated from other areas where this vaccination may not be standard. Other pathogens that can lead to epiglottitis include Strep pyogenes, Strep pneumoniae, and Staph aureus. Overall, epiglottitis is more common in children, but it still can occur in adults who are not immunized against Haemophilus influenzae. Some of the general clinical features include an acute high fever, sore throat, and anxiety. Due to the swollen epiglottis, patients may also experience dysphagia, odynophagia, and drooling. The patient or their parents may also mention a change in their voice, which is often described as a muffled hot potato voice. Patients with a severe case may present in the tripod position. This describes the position when the patient is leaning forward and hyperextending the neck with a chin thrust. This position maximizes the airway diameter and eases breathing in patients with airway obstruction. As the inflammation and swelling of the epiglottis worsens, patients may also show signs of respiratory distress, including retractions, cyanosis, and inspiratory stridor. Here is an image representative of a patient in the tripod position. Notice that they're leaning forward with their hands on their knees. They're also extending their neck, which helps maximize their airway diameter to breathe. The diagnosis is mainly clinical. If epiglottitis is suspected, there are several labs that should be drawn. The labs include a CBC, blood culture, and an epiglottal culture if the patient is intubated. However, if epiglottitis is strongly suspected in a young child, labs should not be drawn until the airway is secured due to the risk of worsening respiratory distress with agitation. If direct laryngoscopy can be performed safely, an erythematous and edematous epiglottis may be seen, which is often described as a cherry red epiglottis. However, this should only be done in patients where the airway can be secured immediately if necessary. Another option for diagnosis includes a soft tissue lateral neck X-ray, which may reveal a thumbprint sign due to the enlarged epiglottis with supraglottic narrowing. Here is an image from an endoscopy showing an inflamed epiglottis. Due to the infection, the epiglottis is edematous and erythematous. The erythema associated with this is what leads to the description of a cherry red epiglottis. Another important thing to note in this image is how the epiglottis is impeding the airway. It's easy to see here how slightly more swelling and irritation could lead to complete obstruction of the airway, which is life-threatening. On the left is a normal lateral X-ray. You can see a normal thin epiglottis in this image. Now let's contrast this with a lateral neck X-ray in a person with epiglottitis. The red arrow is pointing to the epiglottis in this image. Due to the edema and inflammation, the epiglottis appears thick and round, which explains the description of the thumbprint sign. It looks much different than the epiglottis on the left, and it can be easily seen how this amount of swelling can compromise the airway. The most critical part of managing a patient with epiglottitis is managing their airway. The first step is to keep the patient comfortable and calm in order to avoid anxiety and agitation that can lead to acute decompensation of their respiratory status. They can also be provided with supplemental oxygen if needed. The patient should be closely monitored for signs of impending airway obstruction, such as stridor, tachypnea, retractions, and altered mental status. If the patient's respiratory status continues to decompensate with supplemental oxygen, the next step is to provide them with respiratory support with bag valve ventilation and 100% oxygen. However, if the bag valve ventilation is not adequate support or the patient seems to be heading towards imminent airway obstruction, they should be intubated in order to protect their airway. After the airway is secured, the next step in management is to begin empiric antibiotics. Empiric antibiotics should be chosen to cover the most likely organisms, including Haemophilus influenza type B, or HIB. The recommended antibiotics include a third-generation cephalosporin to cover pneumococci, or HIB, and an anti-staphylococcal agent, such as vancomycin. If the patient has a confirmed Haemophilus influenza type B infection, the provider should also ensure that all close contacts to the patient receive post-exposure prophylaxis with rifampin. This is particularly important in those who have not been vaccinated against HIB and in patients who are immunocompromised. All right, let's try a question. A 7-year-old boy is brought to the emergency department due to fever and difficulty breathing. He suddenly felt sick today and his breathing has worsened since the onset of symptoms. The patient is not vaccinated due to parental preferences. The physical exam reveals the patient in distress, sitting in his mother's lap, leaning forward and extending his neck. Stridor is audible and the patient uses scalene and intercostal muscles to breathe. His vital signs are significant for a temperature of 40 degrees Celsius. Arterial O2 saturation is 85%. What is the best next step in the management of this patient? All right, this patient presents with sudden onset of fever and difficulty breathing, accompanied by stridor. He is sitting up in his mother's lap, leaning forward and extending his neck. This is a tripod position that we discussed earlier, and it helps the patient with supraglottic obstruction to widen the airway. He's also using his accessory muscles to breathe and has an arterial oxygen saturation of 85%. Considering that this patient is not vaccinated, all of these findings are consistent with the diagnosis of acute epiglottitis. Since he is hypoxemic and has severe respiratory distress, the best next step in the management is to secure the airway. We can start assisted ventilation with a bag valve mask and 100% oxygen, and we can intubate the patient if he's unresponsive to the initial ventilation therapy. All right, now that we've discussed epiglottitis, let's move on to the last topic, croup. Again, here is the sequence of topics in which we'll be discussing croup, beginning with general characteristics. Croup is a respiratory illness that may also be called laryngotracheitis. It results in inflammation of the larynx and subglottic airway. Croup is most commonly due to viruses, with parainfluenza virus being the most common culprit. However, other viruses such as RSV, coronaviruses, adenoviruses, and enteroviruses can also cause croup. This upper respiratory pathology is most common in children, typically in the age range from 6 months to 3 years. It's also more common in the fall and winter months. Some non-specific clinical features of croup are those associated with most upper respiratory infections, including rhinorrhea, congestion, fever, and hoarseness. Patients may also have a more unique seal bark cough that is classically described in croup. This cough can eventually progress to stridor. With severe disease, patients may experience stridor arrest, hypoxemia, and respiratory distress. It's also important to monitor closely for signs of impending respiratory failure. These include lethargy, severe retractions, a decreased level of consciousness, tachycardia, and cyanosis. Croup, like epiglottitis, is a clinical diagnosis. Laboratory testing and imaging are not typically required. However, if one does obtain an X-ray, they may see a steeple sign that occurs secondary to subglottic narrowing. Here is a chest X-ray that demonstrates the steeple sign of croup. At the arrowhead, you can see inflammation and swelling of the subglottis that has led to a point on the X-ray due to narrowing of the airway. This is the steeple sign, which is named due to the resemblance of a tall, narrow steeple of a church. Patients with mild croup are those who will typically have no stridor at rest, and these patients can be managed at home with supportive care, such as sitting in a bathroom filled with steam, as well as antipyretics. The patients who will be treated outpatient should also be provided with a single dose of oral dexamethasone. For those with more severe croup and stridor at rest, more intensive management may be required. These patients will also need supportive care with humidified air or oxygen, as well as antipyretics. Patients with more severe croup should also receive dexamethasone. In addition, racemic epinephrine should be administered with a nebulizer. It can be difficult at times to determine when children can safely be treated in an outpatient setting and which children should be admitted. Some indications for hospitalization include severe symptoms after initial treatment, altered level of consciousness, impending respiratory failure, supplemental oxygen requirement, and severe dehydration. Here is a summary table of the 2 topics we've just covered. Take a second to pause the video and solidify this information. All right, let's wrap up with the final question. A 3-year-old girl is brought to the physician by her parents due to a severe cough that started 2 days ago. Her parents have also noticed a runny nose and mild fever for the past week. The physical exam shows a somnolent girl with a high-pitched grunting sound on inspiration and episodes of cough. What is the strongest indication for hospitalization of this particular patient? All right, this patient presents with severe cough, a runny nose, and a mild fever. The patient also has a high-pitched grunting sound on inspiration, which is most consistent with stridor. Given all of these findings, the most likely diagnosis is croup. The fact that she is somnolent indicates severe upper airway obstruction and possible hypoxemia causing altered mental status. So somnolence is the strongest indication for hospitalization of this particular patient. And that concludes this section.